Hello, everyone. My name is Dr. Letizia Baxter Smith. I'm a psychiatric mental health nurse practitioner and an assistant professor at Vanderbilt School of Nursing. It is my pleasure today to be the host of a conversation that we'll be having today about a Black doula program. And I want to take this moment to allow all of the panelists to introduce themselves. All right. So if we want to start with Stephanie, if you would like to start.
Sure. Good afternoon or good evening. My name is Dr. Stephanie Devane Johnson. I am an associate professor in the School of Nursing here at Vanderbilt in the midwifery program, also a certified nurse midwife of 25 plus years, a Vandy alum from 1997, and so glad to see all of you all and excited to talk to you about Black maternal mortality and our doula program.
Thank you. We're glad to have you. And Venus, I'll let you go next.
Sure. My name is Venus Standard. I am in Chapel Hill, North Carolina right now. I'm an assistant professor at UNC School of Medicine, also a certified nurse midwife at the Department of Family Medicine.
Thank you. And Jackie, last but not least.
I was like, I guess that means I'm next. So I'm Jackie McMillan Bowler, and I'm assistant professor at Duke University School of Nursing. Also a certified nurse midwife and an alum. Actually, Stephanie and I were classmates, class of 90 something, but you get the idea. So very excited to be here and tell you about our program.
Great. Well, thank you all. So we'll get started with the first question. And I'm gonna send this one to you, Stephanie. Can you tell us a little bit, it sounds like Tennessee is rated high among the other states in the country for maternal mortality. So what does maternal mortality really mean, and what does that mean for people in Tennessee?
Well, the definition of the maternal mortality rate are the number of women who die during childbirth or within 1 year of their delivery. And in the state of Tennessee, 98 women died in Tennessee during or within a year after their death, after their delivery in 2020. And this is based off of the 2022 maternal mortality report for Tennessee. What's so significant is that 89% of those deliveries were deemed preventable. And across the country, not just in Tennessee, Black women are 2.5 times more likely to die than white women, either during or within 1 year of delivering their child.
Wow, that's staggering to think about.
It's staggering. And if some of us are very visual. If you remember being in school and it's an A, B, C, D, or an F, Tennessee and North Carolina are scoring a D at this point. And D's in my house were never good. And so there's a lot of room for improvement.
And Venus, can you tell us a little bit more? I know Stephanie mentioned some of the statistics by race. Could you tell us a little bit more about the statistics by race?
Well, the statistics are monitored in a lot of different factors. Overall by country, state, region, county, city, and race, to name a few. We base the statistics on race in order to be able to compare the incidences, to see the outcomes, to see if one race is more affected than the other race. Now, while some states like New York, for instance, are drastically higher nationally, like Stephanie said, Black women are 2 to 3 times more likely to die from pregnancy-related or associated causes than white women. And when you consider and factor in age, education, financial status, those things you would think would change the rate, but it really does not. So bottom line is a doctoral prepared, financially stable Black pregnant person is 2 to 3 more times likely to die than an 8th grade or lower income white person.
Wow. So Jackie, then that leads me to ask you, why isn't there such a big disparity among the races?
So when you strip away all of the issues that Venus just mentioned, the one that's left is racism. And, our understanding about bias and how it affects how we interact with each other, how people are listened to, how their complaints and how they're reported, how they're responded to, all of those things play into it. So at the end of the day, you are Black or you are Latina or you are whatever, that doesn't change. And so whether you have lots of resources or whether you are limited on resources, that's not going to make any difference. If you're a Black woman, you are more likely to have complications and you are more likely to not receive the same kind of treatment as a similarly positioned white person. And that's what it is. So when it all boils down, racism is the card that we can't remove.
Okay. So Stephanie, I'm gonna come back to you. Has the Supreme Court's decision in Dobbs versus Jackson Women's Health Organization affected care in Tennessee that you know of?
Not significantly. It's, they put some policies and some procedures and things in place, but it has not, as of yet, made a significant difference in the maternal mortality in Tennessee.
Okay. All right. So how did COVID affect maternal mortality rates, Venus?
Significantly. Well, first, just to level everybody on the same playing field, to understand the different categories of maternal mortality. There's associated mortality, which is a death caused within the first year by any means, right? Like a car accident or something like that. Then there's related mortality, which is a death caused in that same first year by a pregnancy-related cause. And then there's maternal mortality, which is pregnancy-related cause within the first 42 days after delivery. So see, pregnancy itself increases the vulnerability of infectious diseases like COVID. Our major organs, our lungs, our kidneys are all working harder in pregnancy, and the immune system accommodates for this person on board, for the fetus, right? But a pregnant person with COVID is 7 times more likely or increased risk of dying compared to an uninfected pregnant person. And that's based on the NIH study. According to other statistics, it was an increase in 40% in 2021 in comparison to 2020. And 2020 had 1,200, a little bit more than 1,200 deaths in 21, where in 2020 there was 800, a little bit more than 800. And it was determined that at least 400 of those 1,200 deaths in 2021 was a direct result of COVID.
Okay. Wow.
And I want to add a little bit to that and just to talk about, the mental health piece. So that was something that wasn't as prevalent prior to the pandemic in terms of being one of the things we monitored in terms of maternal mortality. And there was a lot of isolation and a lot of things that happened that affected the mental health of everyone. But that definitely is one of the things that has continued to affect pregnant persons. And so one of the factors that we have to add to the list in terms of outcomes that we are now watching when we think about maternal mortality is death by suicide and self-harm. And those are issues that haven't traditionally been part of our measurements, but now we understand that the risk around death by suicide for pregnant persons is also on the rise, and it's something else we should be monitoring for as well.
Certainly, I can appreciate that. So we've kind of talked a little bit about mortality rate. We've talked about COVID and how that's impacted things. You've just brought in the mental health piece. So my next question, Jackie, would be how would doulas and midwives start to help with some of these statistics that we're talking about?
That's a really great question. I love focusing on the things that we can do and being positive. And so when we think about childbirth and what happens, it's a very vulnerable time for the birthing person and for the family, both from the standpoint of it being potentially something new and different, and the changes that happen, and walking into a healthcare system. And in some ways feeling like you're at the mercy of those that are taking care of you. So those are some issues. So when you think about midwifery care and the midwifery model that's focused on pregnancy that is not illness related, and we are focused on promoting wellness in pregnancy. Stephanie mentioned the statistics around preventable preventable complications and death. CDC across the board, not just in Tennessee, says that 80% of the deaths from childbirth are preventable. And they're not preventable just because someone's not listened to in birth. They're preventable because of some of the comorbidities that Black people are at increased risk for. So having an opportunity to have someone who spends more time with you, someone who's focused on your wellness, someone who is talking to you about your diet, someone's talking about exercise, someone's talking about mindfulness and opportunities to promote mental health and well-being, that's going to impact how you ultimately experience your birthing experience, right? So a midwife who is trained around wellness and thoughts of promoting that and listening and has a little bit more time, and not for any other reason than that's our model that we set up to have more time with our clients, that gives us an opportunity to really dig into some of those issues that really can impact outcomes. And that's one piece. So the midwife is there during the antepartum period, or when someone is receiving prenatal care. They're there with them during birth. They're there with them postpartum. And don't forget that most of those births that happen are happening in the postpartum period, not in the hospital. They're happening after someone has a baby and goes home. But the doula adds an extra special, I would say that's the extra sauce, the extra special sauce, because they are there as a person that is not responsible for their care. They are there to really walk alongside. They're there to elevate their voice, not to speak for the person, but to allow them to really get to where they want to be. What do they want out of this experience? They're not sick. How can they promote that? How can they promote pushing clients know their bodies. They are the best person to say something's not right, something needs to be fixed. Sometimes they need a little encouragement to use their voice, and the doula is there to help them do that. So the midwife who has a little bit of extra time and focus on wellness, and a doula who's really there and dedicated to really only focusing on that person and helping them to use their voice and to be educated about the process, that is a winning combination. And that's been proven statistically. ACOG has come out in 2017 with a position paper and really talks about how having a doula be present during the birth really does lower C-section rates. And these are things that are facts. They're not guesses. They're not just things we want to say. It's truth. So doulas do have an impact on cost. They have an impact on decreasing interventions, as do nurse midwives. So you have two factors that really help to make a difference in terms of outcomes.
Thank you for that clarification. I know myself, just talking to moms after birth, that's one of the things they often talk about is not being heard. So it's great to hear that that's kind of one of the things that the doula takes ownership of, to make sure that they're being heard and they feel like they're an active participant in that birth process. So thank you for that clarification.
Can I jump in 1 second,
Please.
Letizia? Just to clarify that everything and co-sign everything that Jackie said, but for those who are listening in, a doula is not medically trained. They are not responsible for, again, any lab work, any diagnosing, anything as far as the patient. That's where the healthcare provider, the midwife, or the physician come in at. The doula is there for emotional support, physical support, again, like Jackie had said, empowering and helping the birthing family increase their agency as far as their what their wants as far as their delivery and their care is concerned. But sometimes a lot of people get midwives and doulas confused. Well, what's the difference between a midwife and a doula? Well, all three of us, me, Jackie, and Venus, went to nursing school first. We went back to our respective institutions and obtained a master's degree in certification in nurse midwifery. So we had advanced training and learned Well Woman GYN and how to deliver a baby, postpartum care, to take care of an individual from menarche to menopause. And Jackie and I went a step further and obtained a doctorate in research. So I just wanted to kind of clarify that. And since we get that question a lot, what is the difference between a doula and a nurse midwife?
Thank you. I appreciate it. So then that brings me to a question that we got from an audience member. So I want to make sure that I get this question correctly, but the audience member wanted to know, are there any differences in training a Black doula that other doulas should be educated on as well for equitable care?
Well, I'll start and I'll let Venus and Jackie chime in to anything that I forget. But our program is culturally tailored, meaning we put first the Black lived experience and categories and topics that are unique to the Black lived experience historically and present day. And so I can't give away all of our nuggets of our curriculum, but and I can speak to, I lecture and teach on the historical aspect of breastfeeding in the African American or Black community dating back to slavery, and how the mammy caricature and slavery and wet nursing does impact some African American women or Black women, not all, their decision on whether they're going to formula feed or breastfeed. And then we bring in, reproductive justice and some of the things that have happened historically in the Black community. And so these are all things that are pertinent to bring to the forefront in training our doulas, because some of their participants, some of their clients could be potentially have issues or a negative stigma about certain things. And so if they have this education and this extra set of tools, that they can help those patients kind of move past that or help them in the healing process. Venus, Jackie, did I forget anything?
No, you didn't forget anything, but just to just highlight the training of a doula, the overall training of a doula. If you're a white doula, if you're a Black doula, the overall training is not different. Is the foundation of training a doula is very much the same, but having that training through with, like Stephanie said, with an equity lens is crucial. Now, and not all doula trainings get that. There's clearly a learning curve when training white doulas. A Black doula is concordant to the patients that they see, right? So they could have the same lived experience, both in education, upbringing, financial concerns, social concerns, things like that. They could, not necessarily must, but could have the same lived experience. So that's things you don't have to explain to a Black person taking the doula training, where you may have to explain that to a doula that is white that's taken the training, because that's not part of their lived experience, right? So you have that learning curve in that direction. And in the other direction, while the Black doula could have the same lived experiences, there's things that they may not know why they are where they are. They don't know, like Stephanie talked about, the historical part of breastfeeding. They don't know some of the historical parts of things that brought them to where they are right now. And we kind of review all that.
Great. So then the next question that I had was, what are skills that are required of postpartum doulas? Are those different from the skills that you guys have just discussed?
Yes.
Okay.
Yes, those are very different. A labor support doula is there during the pregnancy, the birth, and the immediate postpartum. The postpartum doula takes over where that labor support doula leaves off. And usually it is about 2 weeks, 3 weeks time. Some people have their postpartum doula from the time they come home. And again, that's a luxury that not everybody can afford, because that's not covered as well by insurance companies, a postpartum doula. The postpartum doula has a little bit more flexibility in their schedule. They can govern their schedule, where labor support doula is at the mercy of the person that goes into labor, right? The postpartum doula makes their, between the birthing person or the person that just gave birth, decide what they're going to do to support them. Are they going to watch the other kids while she takes care of the baby? Is she going to watch the baby while she sleeps or takes care of the other kids? Will she do some light housekeeping? Will she go shopping? So it kind of depends on what they need and what the postpartum doula is comfortable or willing to do. And that is a completely different level of training and certification than we offer.
Okay.
And I would like to just bring it back to the idea of talking about sort of the Black experience in the postpartum. As I mentioned before, many of the deaths that occur that are related to childbirth happen in the postpartum period. And this idea of the birthing person not feeling empowered to know what is normal and what is not. Often the story for people who share the sort of Black experience is that suffering is part of being Black. That's just what happens. That pain is not something that you necessarily can tell someone that you're experiencing and know that they're going to listen to that and respond to that. There are many cases, unfortunately, of Black birthing persons who have shared with someone or shared with a loved one that they were experiencing some complications, but didn't think it was serious enough for them to go to the hospital, and subsequently had fatalities related to that, or they went to the hospital and their cries and pleas were ignored. And so having a doula who understands those potential situations, who could then be the intermediary to say, hey, wait a minute, you're telling me you're having X, Y, and Z symptoms, that needs to be elevated. So they're not going to take over the medical care, as Stephanie mentioned, but they could definitely be a little more insistent about calling a provider and saying, you need to call your provider. No, that is not what you should be experiencing. It is not okay that you are feeling that way, both mentally or physically. And that can make all the difference. If you have air in your lungs, like a pulmonary embolism, being short of air, understanding that that's not normal. Having a fever that's particularly high, understanding that that's not normal. Having exquisite breast pain that's not relieved by normal comfort measures, that's not normal. And everyone does not understand that those are things that require elevation to a provider. And so having someone there that you can call, that you have a relationship with, that you don't feel like you are bothering, because some people don't call their provider because they're worried about bothering them, then those are real things that could be life-saving. And that's what the doula is able to do for these particular clients.
And Jackie, I just want to ask you, I know that Venus just eloquently explained the difference between the postpartum doula, and you mentioned earlier mental health and that being something that you are starting to focus on a little bit more. Do you have any statistics on postpartum depression and how that's been impacted by the postpartum doulas at all, or can speak to that at all from your experiences?
I don't have statistics, but what I can tell you in terms of the numbers is that it is definitely an issue going forward of things that we are now monitoring. Prior to COVID, it was pretty low on the list of one of the causes. We had bleeding and sepsis and those kinds of things on there. And mental health issues were a lot further down on the list. And now they are cropping up pretty high on the list as issues that we really have to contend with. And again, understanding that for a long time, postpartum depression wasn't recognized as an issue for anyone. So whether you were Black or white or Latino or anything, that was not something that was recognized as an issue. So we are just getting to the point that we have recognition around that. But in general, also think about the fact that until 2017, 2018, we were not stratifying mortality rates by race the same way that we are now. So these are all brand new discussions when you think about data collection. So just want to add that in there.
Hey, great. Well, you guys have definitely talked to us a little bit about your program. So I'd like to ask, what would be the best way, or what is the best way that you feel like it is to implement a program like this on a labor and delivery floor? How would people go about doing it?
Jackie?
I think that's my question. So I think what I'm understanding in terms of your question about starting a program like this, it doesn't have to start with labor and delivery. We certainly have models in North Carolina for free doula services, but the part that's important on labor and delivery is that you have support for the doulas who come in. And that's what I just cannot stress enough, that we work as a team. The doulas who come in work as a team with the nurses, with the healthcare providers, with the midwives, with the physicians, anesthesia, everybody, that the doulas are there to work as a team and really elevate the experience for the birthing person. So on labor and delivery, when you think about a program like this, in order to create success, it has to be that we all are supportive of each other in our desire to support this family as they bring a new life in the world. And that's really where it comes from. So our program is not, based in labor and delivery. It is outside of labor and delivery. As Stephanie mentioned, doulas are not medically trained. So their training doesn't need to occur in the hospital, because our doulas could be with persons who are birthing outside of a hospital. They could be with persons who are birthing at home or in a freestanding birth center or lots of other places. So the training doesn't have to be there, but for the doulas who work in a hospital, having support of all the staff so they feel welcomed and a part of the team, and so that there's not any tension that could be there between providers is not there. That is the way that we create success around a program like this in labor and delivery.
Okay, thanks. Well, Stephanie, could you tell us a little bit about your grants and how they might be able to support programs like this?
Yes. So I just give you a historical back in 2018, I believe it was, I was at a different institution and was teaching nursing at a BSN level. And that was when Serena Williams had her near miss with her baby as far as not being listened to. That was when a lot of the Black maternal mortality was illuminated. And I was standing up in front of the class and I had a moment of reflection, like, how can I fix this? What can I do? Do I need to stop teaching and go back to the bedside and start delivering babies again? Because I had retired from that. And then I was just like, no, doulas can be trained in a weekend. Our program is 8 weeks because we add in extra stuff. And so I started brainstorming about developing a culturally tailored Black doula program. Jackie and I were working together at this institution at the time, brought her in, and then have known Venus for many years. And we were just like, we are 3 Black certified nurse midwives. This can be a nurse-driven initiative. And we all got together around Venus's dinner table on a 4th of July and wrote this grant. And when it was first, it wasn't funded through a foundation the first time. COVID hit. I moved from North Carolina to Tennessee, and then Venus called one day. She was just like, "Where's that doula grant at? Let's dust that puppy off," and submit it again at UNC through a foundation. The first one was the C. Harvey Felix, where we were granted $75,000 to start, and that's how we trained the first 2 cohorts. And then we submitted for the Duke Endowment and were awarded $525,000 for 3 years from 2002 to 2025. And are in the 2nd or 3rd week of our 6th cohort. Usually have between 15 and 20 doulas in each cohort twice a year. So that's the history behind it. And so really and truly, to answer your questions about, our program, again, is a doula training on steroids. You can get a donor doula certification, again, within a weekend. Our program is 8 weeks. But the beauty of our program is that we take away the financial barrier to individuals, Black individuals, and you don't have to have any advanced degree or anything, who want to be in the birthing world. So it is free for them. And then we take the financial barrier away from the birthing families. They get a doula for free. A doula can run you $1,200 out of pocket. I don't know how many people have $1,200 just kind of sitting around. And a doula training for the person wanting to do the birth work, can cost $500-$600. And so taking away those financial barriers and getting gatekeepers back out into the Black community to serve the Black birthing people and families was our goal and initiative. And also adding to the workforce, which lines up with the 2021 Vice President Kamala's Omnibus Act, which there's a line item for Black maternal mortality, for doulas, and for adding to the workforce.
Great. Well, we're glad to have you guys in this great work that you're doing. Which leads me, Venus, to ask you, are there any states that are doing this correctly out there, or is it abysmal for everyone?
I don't think any one state is doing it right. but based solely on the overall data, there's some states that appear to be doing it better. And I just say appear to be doing it better because what I looked at was the overall numbers and not by race. So that said, states like the Northwest state, Wyoming and North and South Dakota, Vermont, West Virginia, states like that, their numbers are better. And southern eastern states, like Alabama, Mississippi, Georgia, Louisiana, Tennessee, they have extremely high numbers. So I don't think anyone is doing it right. I just think some are doing it better. And you look at that separation of those two categories of states, and the southern states where they're more Black aligned there versus Wyoming and North and South Dakota that may not have the numbers of Black birthing people as the southern eastern states do.
Okay.
So I think it's skewed a little bit.
That makes sense. Thank you for sharing that. So Jackie, my next question would be, we've talked a little bit about Serena and just the history. You guys have shared history, and this is not something new that's been going on, but certainly something that I feel like a topic that we're hearing more about. So why do you feel that the disparity in maternal mortality is getting more attention now as opposed to before?
Well, I think, again, as I mentioned earlier, the idea that prior to 2018, we weren't really stratifying data. We weren't collecting data around this issue. And so one particular provider started to ask questions about why am I noticing that more of my Black patients are suffering, and then began to really collect those statistics at Harvard. That's when we started looking at it. So we didn't really have this data prior to 2018. And when you couple that along with Serena's story, when you hear stories about Kira Johnson, when you hear stories about Beyonce, people that we know or think we know, and we say, hey, that could be me. But actually, if you go within the Black community, there are stories on top of stories on top of stories of Black women who've been dying for a really long time. So within the Black community, it's not ever been taken for granted about the fact that birth is not always a given, that you're going to come home. And that's a horrible, horrible thought. But it's for Black families, that's not a new statistic. But in terms of the world and how we're looking at it, 2018, we started collecting data, and data talks. And so it is the data and the stories that have come out from people who should not be dying in childbirth because they have the money and the resources and all of that has elevated this conversation. So that's what's changed.
Okay.
I think social media has changed it as well. Prior to social media, women were dying or having near misses, but there was no way to showcase it or highlight it or get the word out there. Now with Facebook, Instagram, TikTok, that I feel as though that's another reason why it's bubbled up to the top and a light has been shined on it, because you can see the Beyonce stories, the Tori Bowie stories, the Serena stories, the Kira Johnson stories, like that we didn't hear about before. But there were famous Black women who had near misses and that died, but it just didn't hit the media circuit. And so now that we have that has elevated this conversation. Like Jackie said, Black women and women just in general have been dying for centuries during and after childbirth. But now with social media and with better data collection, it's becoming the buzz kind of topic right now.
And health equity in general is part of the conversation. It's where the grant funding is. It's where we're doing a lot of conversations about how we've only begun to really pay attention to the inequities that exist within the healthcare system. And those of us many of us are probably in healthcare, which is why we're here. But we all know that maternal care, maternal birth, and babies, that is how we indicate the health of a society. And so it's unfortunate to really, when you look at the bigger data, even across mortality rates, if you look at look at all the birthing people together, why do we live in a country that has as much money and as much resources and as much everything as we have? Why is it that our maternal mortality across the board skyrockets in compared to every other developed country. Every single one. That makes no sense at all. None. So it's letting you know that we've got a lot of issues going on here that we need to really dig into. And so Black mortality is a part of it because we make up the largest portion of that mortality. But it's as a whole, thinking about what we're doing about the care of babies and persons who are birthing those babies, that those are things that we need to really be focused on as a society. So if this gets us there, absolutely, we need to be focused on it, but it's not because it's new. The deaths are not new. It's because we finally have data and we're being forced to pay attention. The optics look bad, and that's why we're paying attention.
Thank you. Thank you. So Venus, we've kind of touched on this a little bit too, but speaking of health equity, can you tell us a little bit about what providers can do to improve care and lower risk?
Well, part of the problem, if you take all of the studies that have been done and the focus groups and the conversations, it's nobody's listening to me. That's the lack of listening is the overarching theme to everybody's concern. So I think providers have to be intentional. They have to become active listeners, listen to her concerns, acknowledge and address the concerns, not just brush them off, because they're her concerns and they're real to her. Believe her when she says something's wrong. That's another thing that's a big thing. They're not believed when something is wrong. Take the time to educate yourself on other cultural things, including the whole picture, her whole picture, that birthing person's whole picture, not just what she presents with that day, with void of assumptions. Don't assume this or judge on that. Look at her picture or their picture, what they're saying, and try to be culturally, they'll never be culturally competent. I don't think if you're not concordant, you could never be culturally competent, but you could be culturally sensitive. You could be culturally aware. You could be culturally in tune. And that's what's needed. That's the part that's lacking.
Thank you. I mean, it seemed like very concrete strategies, but certainly something for us to think about. Stephanie, were you going to say something?
And also, we need more Black nurses, Black nurse midwives, Black nurse practitioners, Black pediatricians, Black OBs. That takes years of training. Our training to get our Black doulas out in the community, like I say, is 8 weeks. But there are also still some myths that are being taught to medical students, residents about the Black community, that Black women feel pain, that if they describe their pain as really high, they're just over exaggerating, or that our skin is thicker. And Jackie teaches at Duke in the nursing program. Venus teaches at Chapel Hill family medicine residence. I teach at Vanderbilt nurse midwifery. So we're attacking all areas of, except the OB realm, but family practice residents that do deliver. And so we're attacking it to dismay those myths. And I tell my midwifery students at Vanderbilt, even when you are taking care of a Black patient and they say that they have a sign or symptom of a certain thing, pretend like it's me and do your due diligence and order the diagnostic test, order the lab work, because it's a thing until proven not. And it's not going to take away from any money out of their pocket, but they need to do their due diligence. Again, don't go looking for zebras, but what I tell my patients, but especially if it's a birthing person and within a year and they're complaining of shortness of breath, they could have a cardiomyopathy or an enlarged heart or a pulmonary embolism, or it could be any number of things, but you don't know that until you order the right test. And so just because certain things are not your lived experience, don't dismiss them and poo-poo it and say, oh, that's not a thing, or she says her pain is a 10, but I read in this textbook that Black women say that they're hurting more than they really are, so it's not really a 10. How do that you don't get to decide that. And the doulas, in the room having one that looks like the patient, and two, potentially having been with the patient the whole pregnancy, can get in their ear if they sense that the provider isn't listening. Say, okay, well, say it this way, and like push back and say it a different way, or ask for a second opinion. Again, the doulas are not their mouthpiece, but they're helping them get the empowerment and the agency to demand that they get the right equitable care.
And I want to jump on Stephanie's comment, that last piece about the idea about education. So there's the piece of not being listened to, but there's also the piece of not receiving the education to know when something is going well and when something isn't. And we don't do a very good job of spending the time with the birthing person and the family to give them the education they need so that they can use their voice, so they know what is not normal, and they know when to come in, and they know how to make healthier choices that perhaps would promote better outcomes during their pregnancy and in their lives in general. So so we have to think about that piece of education. We think about what we can do, making sure that people understand how you get pregnant. Some people still don't understand that. People don't understand how we move through pregnancy, how long a pregnancy is. Some people understand that it's 9 months. And so when they're 36 weeks, they're thinking, why is my baby not coming out? It's 36 weeks. There's some real basic things that we fail to really make sure that people understand. How long labor should be. What are some signs that it's not going the way that it should? That you have options when you come in for labor about how you want to manage your comfort, that having an epidural is something you choose, not something you have to have. You know, these are all things. And in order to be able to be an active participant in that process, you have to be educated, because if you're not, then when you walk into the labor room, you feel like you're at the mercy of all of those people who have the bigger words and the knowledge and the education. And so that's a failure on our part as a society to make sure that the birthing persons have the education to really be able to participate in the process. Because if you don't have the information, no matter how well-intentioned the providers are, they cannot participate. It's very difficult to participate when you don't have the knowledge.
Very, very important. That leads me to ask you, so where would you say that education begins, Jackie? Is that something that we're teaching our nursing students as well? And if Stephanie was talking about some of the myths that we've debunked, but do we start that process with our nursing students, or where would you say that education should begin?
Oh, I think it's multi-pronged. So it's the nursing
Okay.
students, but it's even before that. It's the kiddos in school. You know, it's like we take all of the information about pregnancy, about puberty, about all those things. We've taken all that away. And I'm saying, okay, you take it away, but you don't talk about the things that are normal that we've got to do to make sure that people are able to really have a voice in their birthing experience. So people need to understand that, and that should happen before they get pregnant. You know, why do we not make an investment in really thinking about preconception care? That should be something that everybody has before they even think about having a baby, before it's possible to have a baby, for someone to talk about taking folic acid, right? To make good decisions about exercise, make good decisions about your body and movement. And those are things that really can have an impact on pregnancy, but they have to happen before you get pregnant, because once you get pregnant, it's too late. So we're already predisposing ourselves. So that needs to happen. It needs to be a part of our wellness movement. It needs to happen in schools. It needs to happen at every visit, every time. You know, the March of Dimes has the campaign about that. But let's talk about it every time we go in. So it's not just OB, it's not just labor and delivery. It's everywhere people who have a uterus are. That needs to happen.
Thank you.
And I always say as well, a lot of this, especially for young women, especially young women in the Black community, it starts at home, and teaching them to advocate for themselves, even starting advocating for themselves at school, giving them the words to use, so that as they grow and become older, then they have the tools and have been taught, okay, I know how to advocate for myself at school with my teacher. Now let's use those same skill set to advocate for myself in the healthcare realm, and asking certain questions and questioning. again, I was raised in the South. Yes, please, and thank you go a long way. And there are ways that you can push back and advocate for yourself in a respectful manner without having to, use unsavory words or things of that nature. And so I really try to empower my young mothers who have young girls, like teach them and give them the words to use to advocate for themselves, so that when they get to having a baby, they're not just sitting there going, well, you're the doctor, whatever you say, I'll do whatever it is that you want me to do. No, you know your body better than anyone. And if you feel as if this isn't normal, then say that it's not normal and something that's not right. Not where they have the education, they went to school, they don't know everything. And it's being able to be empowered and have that type of agency about yourself to be able to do that. And that, you're not born with that comes with experience, and that comes with somebody showing you how to do that.
Right.
You have to educate yourself on your rights as a patient, right? We go through this thing called the Black Birthing Bill of Rights, and it seems second nature for everybody else, but it's not when you're taught, like Stephanie say, just to say, you're the doctor, you know all, but the doctor doesn't know you and your level of your knowing your body. And that's real important for you to know that, so you can make educated decisions. You need to know all the pieces to the puzzle, and protecting the community. If you see something that's not right, say something. It's not about calling people out. It's about calling people in, because we want our healthcare team to be doing right by us, not to eliminate them, but for them to be doing right by us. So we need them to have better tools, and we can educate them as providers on how the Black body works. And that's just, going to strengthen the future Black families.
Thanks. That's very inclusive. And I think that's an approach we definitely can take for sure. So we've certainly had a robust conversation. As we're starting to wrap up, I'd like to ask each of you, and Venus, if you don't mind starting us off, I'd like to ask each of you, if you had a magic wand today, what would you ask our audience members to do to start to help with the topic of the day?
I mean, I think I had, just to sum up what I was saying before, to educate yourself. There used to be a store, a men's clothing store in New York, and their tagline, it wasn't called a tagline in the 70s, but their little tagline was, an educated consumer is your best customer. So you are a customer of healthcare, and you have to educate yourself, because clearly, as we've seen, the system is not always going to educate you. So if you educate yourself on your body, what it can do, what it shouldn't do, and what the rights that you have, I think that goes a long way in being able to advocate for yourself. That squeaky wheel and the grease theory, that is true. You have to ask, and if you don't know, you don't know to ask. And that's where the doulas come in to help. You have that voice to be able to help that.
Thank you. Jackie, do you mind?
I do not. I would just add to that the idea that we have to believe that these statistics are true. And I think that that's the place we have to work, because they're horrific. And it sounds so unbelievable that many people don't believe it. And we have to, Rose Horton is a nurse manager down in Atlanta, and she has started a really fantastic program. And her simple slogan is, not on my watch. I recognize that these are statistics and things that happens, and the nurses there all have buttons that say, not on my watch, that I'm going to be present. I'm going to be aware that these things happen, but I am not going to be a party of that when I'm here and I'm working. And so I think that's the attitude we all have to take, is no, I'm not going to not believe it. I'm going to believe that it happens, and I'm going to do everything I can to stop it.
Great mindset for sure. And Stephanie?
Jackie stole mine. She said better than probably what I will get ready to say, was just like, speak up. If you see something that is
wrong, or you see somebody being treated inadequately, say something. And if you have the opportunity, if you are allotted spaces and places around the table, invite a person of color, if you have a +1, to be around the table so that their point of view and their lived experience can potentially be part of the conversation. But it's just, don't turn a blind eye. We've turned a blind eye to this situation for years, decades, centuries. And I tell my students, we've been doing the same thing the same way and expecting different results. That's called insanity. We have to start thinking outside the box. We have to do things different. We have to push, not necessarily like Venus said, push back, but push in. And call a spade is what I like to, that is one of my things that I like to say. Like, it is what it is. And it's not race, it's racism. It's killing Black mothers and Black babies. And so that is what I kind of want to leave the audience with is, you know, use your voice and potentially your privilege if you have it, and speak up for a vulnerable population that doesn't.
Great. Well, let me look. I want to make sure that we don't have anything in our chat before we wrap up. I don't see anything at this point. Anything else that either one of you want to add to the conversation before we wrap up? It's been great. Well, I want to thank all of you for coming to talk to us about your Black Doula training program and giving us some insight on the statistics and things that we can be